retrospective study of 449 time-lapse monitored blastocysts. Please.
Dear chairpersons, dear ladies and gentlemen, first of all, I would like to thank the scientific committee for choosing this abstract and giving me the opportunity to talk about our research on the influence of different oocyte insemination techniques on early and late morphokinetic parameters in a sample of 500 time-lapse monitored blastocysts. As this whole session dedicated to time-lapse monitoring shows, this new technique has emerged as a promising, non-invasive tool to enhance classical embryology selection and possibly even improve overall clinical outcome. Morphokinetic variables have been used in models to predict blastocyst formation and haploid status and the chance of implantation. These variables, however, are also affected by numerous external factors, such as patient and treatment-related characteristics, laboratory and culture conditions. Among these factors, the influence of different oocyte insemination techniques has only been investigated by a handful of studies so far, yielding somewhat contradicting results. The insemination method used has a considerable impact on time-lapse variables. In fact, most predictive models so far included ICSI-fertilized embryos only, whereas the proportion of ICSI cycles is largely variable between centers and countries. This is of importance because each IVF unit has been encouraged to develop its own predictive model, since it has been shown that models developed elsewhere cannot be adopted. In fact, this was the main motivation of our study, because we wanted to determine how to handle correctly a mixed fertilization cohort so that all embryos in the sample could be taken into account. This retrospective review have included the embryos of all consecutive patients who have undergone prolonged embryo culture in a single time-lapse incubator since its acquisition at the end of 2012 until December 2014. The total analyzed sample consisted of 500 expanded blastocysts originating from 238 cycles. It's worth mentioning that by our center's policy, all stimulated cycles were performed in a minimally stimulated or natural cycle IVF, that all embryo transfers were single embryo transfers, and that practically all of the procedures were vitrified warmed ones. This detailed flowchart shows how we have arrived to the previously mentioned sample of 500 expanded blastocysts. More than 1,600 eggs were inseminated or injected with standard IVF and ICSI, respectively. ICSI was used in 71% of the fertilizations. You can also appreciate that practically all cleavage stage embryos were put into prolonged embryo culture, and that the blastulation rate at the expanded blastocyst stage was 44%. Subsequently, almost all expanded blastocysts were vitrified electively, and during the study period, 239 single blastocyst transfers took place, resulting in 75, mostly singleton live births. This table shows the baseline characteristics of the 238 cycles that resulted in the previously mentioned sample of 500 expanded blastocysts. One can appreciate some statistically significant differences in terms of female age, parity, previous IVF treatments, age of the male partner, and total mobile sperm count between the IVF and ICSI fertilized groups. In fact, all of these factors, except one, were in favor of the IVF group. A few words about time-lapse annotations in our study. We have used the consensus criteria as defined by the time-lapse user group published last year in Human Reproduction. Two of our experienced embryologists performed the annotations, and these were also rechecked by a third independent person. We have also introduced two more objective variables at the late blastocyst stage: the time when the blastocyst first reached a defined size of expansion at 130 micrometers to the right, and 100 to the left, sorry, and 160 micrometers here to the right. Now let's take a look at our study findings. First, we have examined the differences between the IVF and the ICSI fertilized group, taking a look at the non-adjusted original data set. It can be readily appreciated that during early cleavage stages, up until the 4-cell stage, there was a statistically significant plus 1.5 to plus 1.1 hour lag for IVF fertilized embryos, but this difference has diminished during subsequent cleavage stages. At the blastocyst stage, however, IVF embryos started to show an increasing advancement, which has become statistically significant at the late expanded blastocyst stages, minus 3.3 to minus 4.1 hours. After standardization to a common time point of prenuclear fading, that is choosing the time of prenuclear fading as a starting point for all static morphokinetic variables, the previously mentioned differences have completely disappeared during cleavage stages, but those at the blastocyst stage have become even more pronounced. The average in means progressively increased from minus 3.2 to minus 5.7 hours. This graph also shows the same result. During cleavage stages, when looking at the non-standardized original data set, the IVF curve, blue line, is slightly above the ICSI curve, orange line. Whereas after standardization, both curves, gray and yellow, become completely superimposed. At blastocyst stages, however, the IVF and ICSI curves are diverging increasingly, which is more pronounced in the standardized data set. Our study has confirmed a previously known fact that there is an approximately 1.1 hour lag in the early development of IVF fertilized zygotes. This is simply explained by the fact that early fertilization events such as penetration of the cumulus cells, interaction with the zona pellucida, fusion with the O-lemma are simply bypassed by the ICSI procedure. After standardizing to a common time point after fertilization, these differences have disappeared completely. Time to prenuclear fading is the most adequate time point to standardize to because it's an abrupt event, only observable during 1 or 2 frames only, and it's also highly consistent with the lowest inter- and inter-observer variability. By contrast, there is no need to adjust for any of the interval parameters, such as CC2, S2, and 3, because they already express the duration of different cell cycle events. There was an increasing time difference for IVF fertilized blastocysts, which was more pronounced with the standardized data set. What could be the underlying cause? We could only hypothesize, but this might be related to a better developmental potential of IVF fertilized embryos, which is highlighted by a higher proportion of good quality blastocysts among them, and marginally increased implantation rates in those blastocysts that were transferred subsequently, although this was not significant with this sample size. Our study is mostly consistent with the 2 previous studies published so far on the same topic. Dalcanto et al. Examined a mixed fertilization cohort of 151 cleavage stage embryos and have found a similar 1.5 hour lag for IVF fertilized embryos, which has subsequently disappeared during later cleavage stages. In a larger Spanish study, a similar delay was found, which has persisted during cleavage stages, but has disappeared after standardization to the time of prenuclear fading. In the Spanish study, however, there were no time differences for a smaller subgroup of blastocyst, time-lapse monitored blastocysts. In conclusion, when examining mixed IVF and ICSI fertilized cohorts, we recommend standardization to the common time point of prenuclear fading. Alternatively, interval parameters that do not require any adjustment can also be used. And finally, we encourage the exploration of morphokinetic variables beyond the cleavage stages to determine the predictive value of different blastocyst stage morphokinetic parameters. Thank you very much for your attention.
David Edgar from Melbourne. This is very interesting. We have seen the same. I think you're suggesting that after the early effects of ICSI disappear, the ICSI embryos are actually growing more slowly than the IVF embryos. And very early in the application of blastocyst culture for embryos, there were many reports that the frequency of blastocyst formation was lower with ICSI than with IVF, even in some sibling oocyte studies, which suggested that it may have been technique dependent rather than the male factor. You have mentioned this. Could you actually separate your ICSI results into those from extreme male factor and mild male factor to see if the male genome is actually implicated in this effect?
The sample was not so huge, and there was also, like in this table on baseline characteristics, not only the male factor was the difference, but also like female patients were 2 years older. There was a difference in paternal age also, and practically almost all of the factors were in favor of the IVF group. So I'm not sure that whether doing any statistical multivariate analysis, if we could find out any cause, but these are just, of course, hypotheses that the male factor might be a reason, but this was not actually the objective of our study, more how to handle this mixed fertilization cohort.
I think it's quite important, because if the ICSI technique is actually having an effect on the development rate of the embryo, once you correct for the more rapid progress to pronuclear fading, then that's an important thing to know about the biological implications of doing ICSI.
Of course.
When we don't have to. Can I just, is it okay to ask a technical question?
Yes. Short question because we have one in the back as well.
Sorry.
Short question.
Please.
Okay, so I'll just ask, one of the difficulties in this is when you can actually put the ICSI fertilized egg in the time-lapse machine. Could you tell me how you actually did that? At what point? Sorry, the IVF fertilized. No.
Yeah, well, the IVF fertilized. So I mean, yeah, we should discuss it maybe afterwards with the help of our
it's quite
laboratory director, but
yeah.
we're pretty confident that the timings were correct. Yeah.
Okay, thank you.
Please.
Yeah, thank you very much. Catherine Rakowski, Harvard Medical School. Again, I think this is an incredibly important question as to whether it's actually the technique or whether it's the sperm that's contributing to the time differences you've observed. So I wondered, following on from the previous discussant, whether you'd thought about looking at your IVF population and asked the question regarding sperm parameters and any changes that you see within that group to see how they might relate to your ICSI population.
Yes, again I can say that, yes, IVF or ICSI fertilization was used in 71% of the whole cohort, so only 29 was actually IVF fertilized embryos, a smaller proportion. And this 500 blastocysts are not so huge, so probably it would be difficult to spot any difference according to the male factor, but this is a very interesting point, of course, so we should look at it, yes.
I just have one short question. Did you consider controlling for age as a confounder, since the IVF patients were 2 years younger, and age has been shown to be a confounder with relation to timing of blastocyst formation?
Because we compared actually the differences in the means, so it was not like a binary logistic multivariate model. I mean, but surely with a statistician helps, probably there are ways to look at it. So
because that could be the explanation for the differences in the blastocyst stage, could simply be a matter of different age, yes, between the two groups.
Okay, no more questions. So we will move on to the next